In Illinois, specialized mental health rehabilitation facilities are meant to be a bridge back to the community for individuals living with serious mental illness. But inside, the physical environment often tells a different story. Investigations have documented active bedbug infestations on patient mattresses and a persistent lack of basic hygiene supplies, items like soap and toothpaste that are sometimes withheld as a tool for behavioral compliance. The clinical experience follows this pattern of neglect. While regulations require 15 hours of structured therapy a week, patients often spend their days idle in common areas, with passive recreation like movie watching standing in for actual rehabilitation. When state inspectors document these conditions, the facility is issued a citation and required to submit a plan of correction, a formal promise to fix the specific issues found. This chart shows how the process often functions as a closed loop. A citation leads to a correction, yet within months the exact same failures reappear. The cycle continues because these interventions only address the visible signs of neglect, the symptoms, without touching the organizational conditions that produced them. To understand why these physical failures recur, we must look at the people providing the care. Many of these facilities face an annual staff turnover rate exceeding 40%. This animation shows the real cost. As staff depart, the institutional knowledge required to maintain a safe environment dissolves. To fill the gaps, new hires are often placed on the floor with minimal orientation. They are expected to navigate complex psychiatric environments without a standardized onboarding process or mentorship. This lack of support extends to clinical oversight. Direct care staff frequently manage psychiatric crises and modify treatment interventions without the required supervision from qualified clinicians. When employees are forced to operate outside their expertise without a functional chain of command, the workplace becomes a site of constant, unmanaged friction. This instability is a deliberate byproduct of the organization's culture, the underlying operating system that prioritizes administrative control over clinical quality. This culture dictates admissions, where leadership may accept patients who require higher levels of care than the facility can provide, simply to keep bed occupancy and revenue high. The system protects itself by isolating anyone who challenges these practices. Clinicians who report safety gaps or attempt to enforce professional standards often find themselves marginalized. A simple safety report can trigger a sequence of retaliatory tactics, from schedule changes to forced resignation. Over time, this filters the workforce. Committed clinicians are removed, leaving behind a staff selected for their willingness to comply. By driving out the advocates for change, leadership ensures that the root causes of the bedbugs and the programming gaps remain unaddressed. This persistence of failure is fueled by a management style that focuses exclusively on the immediate, visible crisis. A facility might throw away a soiled mattress to satisfy an inspector, while the actual cause, lacking a professional pest management contract, remains ignored. Moving past this requires transforming quality assurance from a paper-based exercise for auditors into a process that drives daily staffing and clinical decisions. True improvement is only possible when staff can report failures without fear of retaliation, and when the authority of clinical supervisors is respected by the administration. Without a healthy organizational culture, even the most advanced therapeutic tools and policies will be neglected or mismanaged. Protecting the safety and recovery of people living with mental illness depends on a system where facility leadership is held answerable for the environment they build.